which has been organized by the Kenyatta National Hospital and the University of Nairobi webinar team. We're grateful that we have participants who have been drawn from the government, Ministry of Health, various divisions and departments, from partners, academia, researchers, health institutions, and various cadres in both public and private sector. We also have non-state actors, including professional associations, civic society, the student fraternity, and the community. And I must recognize that we are actually being seen and listened to from very many areas in this globe, the UK, from the United States, coming closer to Africa. We have comments coming in from Uganda, coming in from Rwanda, coming in even from Dubai. So Kenya is on the map. To the presenters and moderators, I appreciate the time you've taken from your busy schedules to unravel what we're saying, the coming of age and what we must do. This afternoon will be very exciting. We have various topics, and these topics include issues that look at cultural practices. Other people call it the indigenous knowledge system. We will be looking at nutrition. And I don't think any one of us is not concerned about the health of our children, particularly when there was school closures and we have all the junk foods that they have participated in partaking. And on the other converse, there are some who have even lacked a plate of wholesome food. Then we will have a look at non-communicable diseases. We will end this particular session by even looking at the trend of cancers as we see them. We have one topic here that is unique in that we will be addressing the community. How do you actually get into the community? And I don't want you to go away. It'll be a long day, but between 5 and 7, we now have the community actually giving us their voices and agency in terms of addressing access to services. Vaccine hesitancy. We are looking at the lessons learned having used HPV vaccination amongst this age group and really beginning to ask, therefore, will they agree or disagree to have COVID-19 when the doors open up for them? So I think we have a very good afternoon and evening. So just to give you a few housekeeping rules, we would wish that the moderators will actually stick our presenters to time. And between the two of you, you will decide who will do the Q&A and who will present the presenters. For me, I will rapporteur on your behalf. Let's all mute our microphones if you're not speaking. If you're sharing PowerPoint slides, you will need to state whether you want KNH to take over or you will actually share your slides. But if you're not sharing them and you're comfortable, you may also open up your video. After each session, so we have 2 sessions today, session D and session E, we will give ample time for discussion. And I will request all of you who are in the audience to please post in the Q&A. And if you must speak, raise your hand. We will try and identify you from the crowd and actually give you an opportunity to give you only one question and to be concise when asking it. The program, I think you have noticed, every single day we keep sharing it so that you're actually familiar with what we have. We also want to take this opportunity to tell you that this is a CPD points symposium. And for those who will not accrue CPD points because you're not health personnel, there is also additional certification from this symposium. So without much ado, I want to welcome each one of you and hand over to the moderators for this session led by Professor Wanyoro. Karibuni.
Thank you, Anne, for the nice housekeeping. On behalf of my co-presenter, who is Joyce, Dr. Joyce, I want to welcome you, all of us again to this exciting afternoon. I'm going to handle the presentation while Joyce will do the question and answer. And I suggest that we have all the presentations, then the question and answer will come towards the tail end. And we have allocated enough time to answer as many of your questions as possible. So without wasting much of the time, I want to invite our first presenter, who is Hassan Mohammed. Hassan Mohammed is going to talk about female genital mutilation, lessons from the Northeastern. And we hope that he's going to elaborate on why this female genital mutilation still persists 20 years after Kenya made it illegal in 2001, that this is an illegal act. Welcome, Mohammed. So Dr. Kenobi, I hope Mohammed is with us and he has shared the presentation. Is Mohammed with us?
I hadn't seen him as yet.
Okay, maybe if as we wait for him, maybe we can go to the next, our next presenter, who is Dr. Anne Mwangi, so that we don't waste a lot of time. Dr. Anne Mwangi is from the Ministry of Health, and she's going to give us a talk on the holistic approach to the challenges of health in relation to the adolescents, especially in the community. Remember, our adolescents are usually in the community, and we will want to hear what approach or which approach we can use so that we can holistically address their health challenges. Welcome, Dr. Anne Mwangi.
What? I'm in a meeting. Hello. Hello, everyone. Good afternoon. My name is Dr. Anne Mwangi. I had shared my presentation with Dr. Kinuthia. Dr. Kinuthia, are you able to project for me?
Dr. Kenodia, please project for Anne Mwangi.
Nelson, yeah, there's somebody, Nelson, yes. Yes.
Okay, you can, yeah, thank you. So my name is Dr. Anne Mwangi. I work with the Ministry of Health. I head the Division of Adolescent and School Health. And so we basically look at both adolescent and school-going children, specifically those in basic education, that's high schools and primary schools. The purpose of my presentation is to just bring to our knowledge what we are doing as a division in terms of addressing the challenges that adolescents are facing in the community. And I will be talking about the community handbook for engaging adolescents, parents, and community leaders. And this document, we developed it last year during the COVID season. And one of the reasons why we came up with it was because after the prolonged closure of schools, then a lot of people are asking, what can we do to engage adolescents in the community? So when we embarked on the development process of this handbook, of course, because of the timing and the kind of meetings that we were doing that time, it took us quite a bit of time to complete the handbook. And it's until this year that we were able to have the document, the handbook signed, and we are in the process of having this handbook. We are in the process of having the handbook going out to the community. So the handbook was developed jointly by the Division of Adolescent and School Health and the community, the Division of Community Health Services. And so when you look at my first slide, that this page where you see two ladies, that is basically the cover page of the community handbook. And you can go to the next page. And as we were discussing the several issues that adolescents are facing in the community, I felt that really this handbook could not have come at any other time, because we have tried as much as possible to address all the challenges that adolescents face in the community, because this being the first book of a kind that is addressing both the adolescents themselves, their parents or guardians, and the community leaders. So the goal of this handbook is to promote the health and well-being of adolescents in Kenya. And we have 3 objectives, one of which is addressing, each of the objectives is addressing the different target groups. The first objective is addressing the adolescents so that we equip them with knowledge and skills on their health and social well-being in order to help them navigate through life challenges and ultimately achieve their full potential. The other objective is to build the capacity of parents and guardians to effectively engage in dialogue with their adolescents in handling their day-to-day challenges and to support them to make informed decisions. The last one is to engage and equip community leaders as champions in addressing the negative social norms and practices that hinder optimal development of adolescents. Next. So the handbook was developed to address the health and social challenges that are affecting adolescents in the community. So we looked at some of the risks, like the risk sexual behaviors that we know have led to lead to teenage pregnancy and also exposure to STIs and HIV. These are things that we have discussed in the last 2 days. Also addressing sexual and gender-based violence, unhealthy diet and physical inactivity, alcohol and drug use, harmful cultural practices, which include FGM, which I think someone will be speaking about, that leads to child marriages, then child labor and engagement in criminal activities. All these were some of the challenges that were brought out as we were thinking through on the development of this handbook. Next. So the purpose is to equip adolescents with knowledge and skills to basically understand their own health. And also in terms of parenting, there has always been a question, how do we engage parents? And also the question of parents, are the parents too busy to engage adolescents, or is it that they lack skills? So we felt we also needed to look at the aspect of positive parenting and equip parents with knowledge and skills to provide positive guidance and regular dialogue with their adolescents, because that is also something that is really lacking, where parents are not able to engage in dialogue with their adolescents. And then looking at community leaders, we know they have a role, and we are looking at everyone in the community who is a leader, including the Nyubakumi, the people who lead groups in the community, the parents themselves are also leaders in the community, but also looking at the administrative arm in the community, the chiefs, the sub-chiefs. We are also looking at the county commissioners, the sub-county commissioners, because all these are the people who provide leadership at community level. And also reducing the social risks, like around alcohol. If we have so much alcohol in the community, then automatically majority of the children will start drinking alcohol. If it's the norm in a community for girls to get pregnant and drop out of school, then you find some of these things are issues that need to be addressed, not just directly on the adolescents or the parents, but they need to be addressed at community level. Then around law enforcement, because we know we have laws. We have laws on alcohol for less than 18 years. We have laws that people should not sell alcohol we should not have illegal brews in the community, and we know those brews are still there. So we have laws, and unless the community leaders themselves take it up upon themselves to enforce those laws, then they do not contribute to the health of the people in the community. The other thing is change of social norms. They can promote change of social norms. So basically we were looking at a holistic approach to the challenges that adolescents face in the community, as opposed to equipping an adolescent who is living in what we would say, quote unquote, in a toxic environment. We felt we needed to address not just the adolescents themselves, but the home environment and also the community environment. So basically this handbook will help to implement a community-based program for adolescents. Next. So the topics that we have covered in this handbook, which has 3 sections, include COVID, because having developed the document during the COVID season, we took quite a bit of that to discuss COVID, how they can protect themselves and how to stay safe. We also brought in the issue of life skills and values, setting goals in life, like just supporting adolescents to set goals, because if they set goals, then they know what they want to achieve in life and they will work towards that. We also talked about growth, development, and sexuality, abstinence, and if somebody is ready to face the consequences of engaging in sex, nutrition and physical activity, and also support network, mental health and well-being. We also included, just next, we also included issues of risk sexual behavior. We've talked about adolescent pregnancy, issues around ANC, skill delivery, postnatal care, child care support, especially in the parent section, how they can support the adolescents to take care of the child and also to return to school. Because, and I know we discussed this quite a bit again in the last 2 days around return to school policy for adolescent girls. And we have tried to bring in the issue of parents taking, not marrying off their daughters and not giving up on them when they get pregnant, but getting them back to school. We have also addressed STIs and HIV, SGBV, and FGM. And we have also addressed child marriage. These are some of the pictures in the handbook. We've addressed child marriages, child labor, alcohol, drug abuse, and also criminal gangs. And as we were looking at the document, we have looked at all these subtopics within the 3 sections of the document, the adolescent section, how just the information that the adolescent needs to be able to deal with those challenges. We have also addressed the information the parents need to be able to address those challenges, and the information that the community leaders need so that they can be able to support adolescents in their community. So that's how we have structured the document. So the adolescent section, this is just an extract from the handbook. We have talked about those all those subtopics that I have talked about. Look at the next. Then we have the next page. Then we have the parent and guardian section, which again we have addressed some of the key things that we felt parents needed to understand about adolescents. Then we have the next section, which is on the community leaders engagement. Next. Where we also tried to discuss what community leaders can do to reduce the prevalence of teenage pregnancy in the community, alcohol and substance use in the community, SGBV, FGM, child marriage, child labor, and how to address issues of children engaging in criminal activities. So the content of this document, especially for adolescents, it will be delivered by those who work in communities, like community health volunteers, community youth groups, or any community work that goes on. We expect that those who are implementing community health programs, because this document is pure, it's a document that will be implemented within the existing community structures. Right now in the country, we have community health units in every county. And so it will be implemented within the community structures. And so the community workers, let me call them community workers, because for adolescents, people may not necessarily engage community health volunteers. They could choose to engage other youth workers in the community who will be able to deliver this content to the adolescents, like in small groups. And we also felt they can also deliver the content randomly on need basis. If a community or a youth worker visits a home, finds a pregnant adolescent, they can engage them one-on-one and discuss issues around ANC, around skill delivery, around child care, around return to school. They can help them set goals, how they can go back to school. They can, basically the content does not have to necessarily be delivered in groups. It can be delivered in one-on-one sessions. And where possible, also utilize the virtual platforms. And for physical meetings, we have proposed that people can meet in the churches, in schools, in social halls, in playgrounds, and other community spaces. And of course, ensure that COVID-19 MOH infection prevention guidelines are followed at all times. We would also want this delivery of content to adopt a mentorship program where we get mentors who can also become role models for the younger adolescents. And the facilitators, whatever facilitators we utilize at the community level, they should agree with the parents so that they know what time they are meeting with the adolescents where, so that we also don't bring conflict during the delivery of this content. Next. For parents, we were looking at engaging them in the existing community groups like Nyumbakumi settings, women groups, welfare groups, church groups, because the content that parents need to know, they can, wherever they gather, the community of volunteers or other community workers can meet with the parents in small groups and take 10 to 15 minutes to discuss the different topics. Then randomly, as need arises, for instance, if you have a parent whose child probably is expectant, they can just meet with the parent and discuss what the best plans are for that child so that they can go back to school, so that this, and how the parent can support the girl to the baby with its child care services. Where possible, again, we do not want to leave out the issue of virtual engagement. Of course, this probably in urban settings or where parents have facilities for internet. And during community dialogue days also, they can work with the chiefs and sub-chiefs and the community leaders to know when they can also discuss certain topics. You can be given a slot to discuss like a prevailing topic in the community. Again, we insist that the observance of MOH COVID prevention and control guidelines is adhered to. Next. For community leaders who are also the gatekeepers, we are looking at high-level engagement, starting with engagement at county level, going down to sub-county level, and then the village level, depending on what is the prevalent issue in that county. Like if you're looking at a county where FGM is the main issue, it would be good to start up at the county level, sub-county down. If it is issues around whatever issue is prevalent in that community, then we are looking at them, like I said before, enforcing, maintaining and enforcing rules and regulations, reinforcing community agreed upon actions, supporting communities to adhere to set guidelines, including the laws and regulations, the existing laws, and creating an enabling environment to facilitate the engagement of parents and adolescents, because it's only the chiefs and the people in the community who can facilitate these conversations. So again, they can also support during their own meetings with the leaders, with the community. They can also provide opportunities for the community health workers to be able to discuss some of the topical issues within their chief barazas and community dialogue days, like I had mentioned before. So the next steps is we have planned, as I said, this document is not launched as yet. We plan to launch it on 13th of May that's next month. And then after that, we start off with the national dissemination forum, then go to county disseminations to be training of TOTs, and then do the sensitization of community health volunteers and other community level workers. So basically that is what we are doing. It's like a proposal, because that's what we intend to do. We also intend to do a lot of mobilizing community, people working at community level, so that, because that's where the document will be implemented. We know so well at national level, we are not doing direct implementation, but this is a document that will come in handy to support engagement of adolescents at the community level. And it's also a document that is not just looking at one aspect of the adolescents, but also bringing on board the parent and also bringing on board the community leaders. So basically, that is it. We hope that once the document is implemented, it is going to change how we handle adolescents.
Thank you,
And how the
Dr.
country as a whole. Thank you.
Thank you, Dr. Ann. I think this is a well-thought document that is looking at the holistic issues of adolescent, and I'm happy that it involves all the stakeholders, the parents, the teachers, and the community, especially the community leaders. I think this is a well-thought document. Although since it is not yet finalized, I think you should look at the cover, so that it doesn't look like it is only made for the girl adolescent, and also look at where we have the parent part, probably put a girl, and where we have also the community, we can also have a few girls in the photo, so that they don't feel that probably the girl also does not belong to the community. I think we will interact with the document and will give you more ideas. So our next presenter is Dr. Shabibi. Dr. Shabibi is going to present on behalf of Josephine Odigo. And Dr. Shabibi is an obstetrician gynecologist in Coast General Hospital. And she's going to tell us about the vaginal practices, especially in Coast Province, and more so among the adolescents. And we hope that she'll tell us this notion of vaginal practices, or what informs this notion. Welcome, Dr. Shabibi. Dr. Kenodia, do you have the presentation for Dr. Shabibi?
Dr. Nyoro, I don't
Yes.
see Dr. Shabibi.
Okay. So if
Yes.
Dr. Okay, fine.
I think we may move to the next one. Yeah.
Okay. So since Dr. Shabibi is not yet has not logged in, I think we'll go to the next presenter, and our next presenter is Ms. Veronica Kirogo. Ms. Veronica is from the Ministry of Health, and she's going to talk about why scaling up appropriate nutrition among adolescents is important, especially in this era where we have issues of undernutrition and overnutrition amongst our adolescents. So over to you, Veronica. Is Dr. Kenodia, is Veronica with us? Dr. Kenodia, do we have Veronica? Or Reira Akinyi? If Reira is presenting on behalf of Veronica, then we can put the presentation on.
Nelson, can you confirm you have them on?
We currently
Nelson?
don't have presentation on our end. Sorry.
So we can, as you thought, maybe the scaling up nutrition, we can move to Valerie. Dr. Valerie Mwendwa, is she with us?
Apologies, Dr. Mwenda hasn't joined as well.
Okay, what about Dr. Eri Odogo? Or Dr. Eri Odogo had indicated he was.
I'm here.
Yes.
I'm here.
Welcome, Dr. Eri. So I think as we look for the other presenters,
Okay.
we will have Dr. Eri Odogo presenting for us on the trends in oncology in adolescent and youth. Dr. Eli is an obstetrician gynecologist who has specialized in gynecology oncology, and he is the chief gynecologist, gynecology oncologist in Moi Teaching Referral Hospital. And maybe as many of us know, he is our immediate past president in the Kenya Obstetric and Gynecological Society. So he's going to talk about this issue of the gyne, on the trends in gyno-oncology among adolescents and youth. And you know, this has been for a long time an issue that has been neglected in the low and mid-income countries. So welcome, Dr. Odongo.
Thank you for the opportunity to present on trends in gynecological oncology among adolescents and youth. I will be providing an institutional experience from Moi Teaching and Referral Hospital, where I am chief of gynecologic oncology. I don't know if I'm supposed to move my own slides or somebody to move them for me. Next slide.
Dr. Kenodia, please move the slides for Dr. Odongo.
Or I can actually, if you give me sharing rights, I can just share, because I'm trying to share, it looks like it's not going through. Let me try.
Okay.
I don't know if you can see my slides now.
Yes, we have the first, the page slide. Yeah.
Yeah, so I have no conflict of interest to disclose, and those are my contact. That's my contact information for those who may want to get in touch with me. A few introductory remarks is that gynecological cancer refers to any cancer that has its origin from the female reproductive tract. And each cancer is unique in terms of its signs and symptoms, risk factors, and prevention strategies. So being female, all women are at risk of getting gynecological malignancies. And this risk increases with age. And as with most cancers, treatment for gynecologic cancers is most often effective when it is caught early. That is the picture of our gynecological, of our cancer unit. We call it the Chandaria Cancer and Chronic Diseases Center. And in this unit, we manage children, women, young girls and adolescents with reproductive tract cancer, reproductive tract cancers rather. So this presentation is derived mainly from our work at the unit. And we are going to sort of summarize the data into this presentation, because we know that if I don't have data to present, I'll just be giving opinions, and some of you will just be making noise. So the source of this data is mainly from the studies that we've looked at, some of them prospective, some retrospective, and also from the multidisciplinary tumor boards, from the institutional collaborations with North American universities and international gynecological cancer society. So the main types of cancers that affect this population, we classify them mainly into ovarian, uterine, cervical, vaginal, and vulva. And we've noted that most of the ovarian cancers that affect this population is germ cell tumors, followed by the sex cord and stromal tumors. However, we also have witnessed a few cases of ovarian lymphomas, because mainly we get patients referred from Western Kenya, some with Burkitt's lymphomas affecting the ovary. Regarding the uterus, most of them are embryonorhabdomyosarcoma, also known as sarcoma botryoides, which also affect the cervix, and a few cases of squamous cell carcinoma that has been reported. The treatment options we mainly offer in our unit is mainly surgical. And because these tumors occur in young women, we offer what we call the fertility sparing surgery, also known as fertility cytoreductive surgery. Some of these patients require neoadjuvant treatment depending on stage of disease. Radiotherapy is rarely indicated because we know the effects of radiotherapy being permanent sterilization and long-term fertility issues. So it's rarely indicated, but occasionally we've had some patients with germ cell tumors, specifically dysgerminoma or recurrent sex-cord stromal tumors requiring radiotherapy. Hormonotherapy is of concern to us because many times you receive patients who have been operated on elsewhere and they have actually undergone permanent kind of sterilization in terms of removing of bilateral oophorectomy. And these patients will require hormonal therapy for the rest of their lives because they are young patients. They require it for development of their bones and other systemic needs of the hormones. So first, I'm going to give a few excerpts from these studies, not yet published. We are still doing the data analysis. This is preliminary data. So it's actually hot from the oven on epidemiological and pathological features of pediatric and gynecological cancers at Moi Teaching and Referral Hospital. And we looked at a 10-year review, and from this we find that the age distribution of gynecological malignancies is actually more common between from 10 years onwards. Like you can see, 10 to 14 years accounted for 39.5%, and 15 to 18 years accounted for more than half of those cases. And this is just what are the type of cancers we are looking at in this population. Initially, we thought that epithelial cancers sort of occurs mainly in older women, but from this study, we found that we reported a few epithelial cancers, epithelial ovarian cancers in women who are actually teenagers, around 3 of them. But you can see the bulk of it all was in the germ cell tumors, which accounted for more than half of the cancers that we've reported. And if you break it down further, you can see that the commonest histology is still dysgerminoma, accounting for 39.3% of the cases. But also we noted that there was sex-cord and stromal tumors, and the commonest is still granulosa cell tumors, which accounted for 75% of cases around for that particular group. Regarding the cervical and vaginal tumors, this has not been left behind because we see we are seeing an increased number of cervical and vaginal tumors, and quite a number of them is embryonal rhabdomyosarcoma. But interestingly, we also have reported squamous cell carcinoma of the cervix. So I'm going to report later on from our studies on the vulva that we've also seen also a few cases of vulval cancer. So when we look at these women who come with the abdominal bleeding in this age, we should always be on the lookout. And our findings is not at variance really from what has been described elsewhere, because this slide talks about the incidence and commonality, whereby germ cell tumors are still the commonest, ovarian germ cell tumors are still the commonest, and they arise in young women between 10 and 30 years, representing around 70% of the ovarian neoplasms in this age group. Though vaginal and vulvar tumors are rare, we are seeing embryonal rhabdomyosarcomas in this age group, even in our particular geographical location. And this is in line with what has been described in the past by Denha, Jamberowski, Fernandez in the previous publications. I thought I would place a lot of premium on germ cell tumors because we refer to them as the good tumors. They are referred to as good because they are very chemosensitive. They are typically curable even with metastatic disease. And they tend to arise from the primordial germ cells. And the subgroups are, as like I've indicated, the teratomas, the dysgerminomas, ESTs, embryonal choriocarcinomas, and gonadoblastomas. These are real pictures, it's not fiction. This is pictures from our unit. When you do a surgery and you find these tumors, you find that you see there is teeth, hair, sebaceous material, and this is typical of the teratomas that we see in our unit. I wanted to stress this also, that cervical stromal tumors, which we thought initially that occurs in older women, actually accounts for around 12% of tumors in women who are less than 30 years of age. Notably is that these tumors are hormonally active and they're associated with physiological and pathological signs, which I'm going to show you in a moment on some patients that we've managed in our unit. And the characteristic of stromal tumors, before I just show you the few of the cases, is that we mainly diagnose them early. They're low grade, they don't have a lot of lymph node spread, and prognosis is pretty good. Now, in this part of the world, we believe in, quite a number of us believe in superstition, and this baby was brought to us 9 months old by the mother, having thought that she had been bewitched because the baby started developing acne vulgaris and breast development. Also, the mother noted that the child had pubic hair and also had a bit of abdominal swelling and was also having menses at 9 months of age. And this just to reiterate the fact that some of these tumors have virilizing properties and they present with abnormal uterine bleeding, abdominal enlargement because of the enlarging tumor, or just the presence of ascites. And this particular baby, we did fertility sparing surgery, ended up being a granulosa cell tumor, stage 1C, and underwent adjuvant treatment as per protocol. I also put up this case to reiterate two things. One, the importance of specialist care. This was another child, 3-year-old, who presented with breast enlargement, and the external genitalia was normal. The hymen was intact, but had an abdominal mass around 8 by 12 centimeters. And as you can see, this is a 3-year-old child who was having a bit of vaginal bleeding and maturing external genitalia with a bit of pubic hair. And this child had been seen elsewhere. And what they had done is that they took a needle and tried to find out what was in the abdomen, and actually went through the tumor and actually upstaged her. And we managed this child, as you can see, managed to do fertility sparing surgery. And this turned out to be stage 1C2 because of the previous needle puncture that she had undergone. We did right salpingophorectomy and omentectomy and underwent adjuvant treatment. We, in our unit, we place a lot of premium on multidisciplinary consultations. As you can see, this is a photomicrograph or H&E staining of the case I've just shown you. There was a debate whether we are dealing with a granulosa cell tumor or embryonal carcinoma. As you can see, this was a lot of discussions went on with our colleagues, even our collaborators from North America, and it was turned out to be embryonal carcinoma. The child received the appropriate care. Now, these are our survival estimates from our unit, and I'll see whether I'll be able to explain it to you so that we can all have this for our consumption. And what we've realized from this Kaplan-Meier survival analysis is that patients who have undergone primary surgery or those who undergo surgery after suboptimal debulking actually did not have a very good survival as compared to those who underwent fertility sparing surgery. If you can see the pink line there, fertility sparing surgery actually underwent, had very good survival estimates. So much as we generalize and say that the cancer response is okay, germ cell tumors and treatment of cancers in adolescents is okay, but from the data we are seeing is that if we don't achieve optimal debulking, if we don't achieve, or those patients who come with advanced disease, actually the survival is not as good as we initially thought. I'd indicated that I'll talk a little bit more about vaginal and vulval cancers, because we've seen quite a number of our young girls coming with mucosanguineous discharge. Some of them may even have polypoid mass protruding from the vagina, suggestive of sarcoma botryoides, and others come with the overt bleeding. In relation to this, we looked at retrospective data of our patients with vulval cancer. And as you can see there, actually, we thought vulval cancer occurs only in elderly women, postmenopausal women. that you can see there around around 11% occurred in patients who are less than 39 years of age. As we know, there are two types of vulval cancer, type 1, which is HPV related, and type 2, which is really occurs in older women, P53-driven mutations, and each scratch cycle. So we can see that vulval cancer occurring in this age could be attributed to maybe HPV exposure, early sexual debut, because when we looked at the histological subtypes, most of them were warty or basaloid, which really showed that could have been HPV exposure pretty early in these young women. And you can see this just to depict the pictures of patients we managed. So the middle there was a patient who was referred to us from Mombasa, with actually the features I've just described in the previous slide, mucosanguineous discharge for a couple of months, and this prolapsed. After avulsion, it turned out to be embryonal rhabdomyosarcoma, and we went back in and did a proper surgery for her. The other slide, a little bit lower, was a young girl who did not really survive long. This was a very marasmic child, and actually the cause of her demise was really not related to the surgery. It was related to malnutrition. This presentation, I thought I would put something on gestational trophoblastic disease, because this is one of the most curable cancers that we've ever managed worldwide, even in our unit. And you can see from our data there is that the distribution of gestational trophoblastic diseases, including neoplasia, actually the one who bears the brunt of this disease is actually young people, adolescents. Those less than 20 to 35, from 20 to 35 years, around 63%, and 13 to 19 years, 6.7%. So you can see that GTDs is not as uncommon as we thought, and is really affecting the adolescents and young girls. So thank you very much, and that is sort of a summary and an overview of the trends that we have seen at MTRH, which has provided us with institutional experience. Asanteni sana.
Thank you, Dr. Odongo. I think this is a very enlightening presentation. Some of these tumors, we thought that they are not that common, or you cannot see them in these young girls, especially a squamous cell carcinoma, because we have always associated them with those women in their reproductive age. Maybe you tell us, among these tumors, especially the ovarian tumors and these vaginal tumors, which is the best way? Probably, is there a way that we can screen these adolescents for these tumors? So as maybe during the question and answer time. And of course, I think the takeaway message here is that we need to look for these tumors and probably send the young girls or any woman with a gynecological malignancy to the gynecological oncology people where they are available, so that we can improve the primary surgery and also improve their survival. So thank you, Dr. Odongo. Our next presenter is Dr. Anissa Boro. Dr. Anissa is a consultant obstetric gynecologist in the St. Luke Trauma and Orthopedic Hospital in Eldoret. Why she's here, of course, we are not talking about trauma, but about adolescent gynecology. So she is a gynecology oncology fellow at Moi Teaching Referral Hospital, with a lot of interest in pediatric gynecology malignancies, as well as palliative care. Dr. Anissa is going to present to us on HPV vaccine hesitancy and what this means to us when we are rolling out the COVID-19 vaccine. Welcome, Dr. Anissa.
Thank you so much for having me and for allowing me to present at this very, very useful symposium. Based on the topic of today, I'm going to share a study that we did on the knowledge of cervical cancer and acceptability of prevention strategies among HPV vaccinated and HPV unvaccinated adolescents women in Eldoret, Kenya. This is a paper that was published in the Bioresearch Open Access document, and it's available for anyone to go read and download. So I have no potential conflict of interest. And so a bit of introduction, cervical cancer prevention strategies have been focused on secondary methods, with all the attention being put in women, sexually active women who are 20 to 45 years old. However, we've noticed that there are sexually active adolescents, and they tend to have a very high HPV prevalence. And most of them, within 50 to 80%, tend to develop active HPV infections within 12 months of sexual debut. And as we have discussed in different forums during this session, we've seen that the age of sexual debut for Kenyan females has decreased from 17 years to 12. Some data shows even as low as 9 and even 11 years. But we find that despite all this, the knowledge on HPV and cervical cancer is still relatively low amongst these adolescents. And we've seen in the last, say, 10 to 15 years, there's been this inception of the HPV vaccines, which have been proven effective in the prevention of HPV infection and associated disease. So based on this, in 2012-2013, there was a hospital-based HPV vaccination in Eldoret under the Gardasil Access Program. It was able to reach 3,000 girls. And following that, there was an assessment of the determinants and subsequent uptake of the vaccine, focusing on some 10 public schools. Also a paper by Vimandia and Dr. Mabea, which is available online. Now, based on this, I wanted to find out exactly what is happening with our adolescents. Most of the talks have been focused on their mothers or their caregivers, but what about the adolescents who are primarily the ones who get infected? And as Dr. Odongo has said, we're seeing a lot of young women coming in with even cervical cancer. So now, over the last decade, we've had the secondary prevention strategies, but we're still having a rise in incidence of cervical cancer. Another thing is that, as I've already said, we really need to incorporate the primary prevention strategies amongst the adolescents and see exactly where we can reach, and even see if we can reduce cervical cancer development in our young women. And currently, as it stands, there's quite a dearth of data on how the adolescents, or how much they know about cervical cancer, whether they know how to prevent or protect themselves, and whether they can accept some of these prevention strategies. So the main reason we are focusing on adolescents is because they have anatomical and physiological predispositions that increase the susceptibility to HPV. For one, their cervix, their endocervix is biologically placed externally, meaning that any infection, especially HPV, which targets the endocervix, it is they're exposed in terms of ready infection. In terms of physiological capabilities, they have poorly developed immune system, or not well developed immune systems, and this means that they cannot clear the virus as well as you would expect a woman who is 25 years and above. And at the same time, for the current age group that is set for primary vaccination, these are young girls between 9 and 14. Most of them have not begun their sexual debut, and they've not been exposed to HPV. Thus, they are this target age group for successful vaccination outcome. And this, I know, has been quite a bone of contention for people, bringing up a lot of HPV hesitancy, in that, why are we targeting adolescents? And by just these two factors, we understand that these adolescents are a special group. And if we can be able to vaccinate them, then we can be able to lower their rates of development of HPV diseases associated, leading to cancer, And so it also comes to mind that the more we increase the adolescents' awareness of the contribution of modifiable life factors to cervical cancer, it just may influence their lifelong patterns of healthy behavior. I'm talking about increasing the age of sexual debut, reducing teenage pregnancy, which we have seen it is quite rampant amongst our population. We're going to help them or talk to them, avoid smoking, avoid alcohol use, because with smoking, it's a predisposing factor to cervical cancer, and alcohol leads to behavior that leads to infection by HPV. And of course, we can always counsel them to be able to limit the number of sexual partners and also always practice safe sex. And with all these factors in place, we can actually lead to a successful reduction in disease burden and control cervical cancer in Kenya, in line with the WHO strategy of the 90-70-90. So the main objective of this particular study was to compare the vaccinated and unvaccinated adolescents' knowledge regarding cervical cancer, to know what their source of information is with regard to cervical cancer, and to see for those, these adolescents, are they amenable to accepting cervical cancer prevention strategies? So I'm not going to bore you with the details of the study itself, but I'll just highlight a few things that we need to be aware of. Now, when it came to knowledge of cervical cancer, the HPV and its risk factors, we found that, of course, most of those who are vaccinated, about 96.7%, they had ever heard of cervical cancer and of the HPV vaccine. And as expected, those who are unvaccinated were a bit low on knowledge, especially about the HPV vaccine. What was also striking was that not many adolescents who are not vaccinated knew that HPV was a sexually transmitted virus. And we find that even the youth currently and young women still are not aware that HPV is sexually transmitted. People are mostly focused on HIV, and they forget about, or they do not know about HPV. In terms of risk factors, it was equivocal between the vaccinated and unvaccinated groups, and both seem to be aware of the risk factors that predispose people to cervical cancer because of a HPV infection. Now, in terms of screening modalities, most of them were not very aware about the kind of screening modalities that were available. And of course, in that way, when the time comes for them to be screened, they wouldn't actually know which one to go for if screening was done to adolescents. And the point of this particular question was actually to bring awareness to whether they're aware that cervical cancer can be prevented or not. And I must admit, for both groups, they did think that cervical cancer could be prevented. And as it came out later, it was mostly as a guess because of the fact of the vaccination process that had been ongoing, especially for those who had been vaccinated before. In terms of what are the source of information, we tend to think that the current generation, they mostly use the media to find information. However, from this study, it came out clearly that for the adolescent, maybe in just this region, they tend to rely on the schools for information. They will rely on their teachers to teach them about cervical cancer, to teach them about sex education. Not many of them will get this information from their homes, from hospital, and not all of them have access to the media. So this shows one of the avenues that we have in communicating to the students. Now, when it comes to the self-perceived risk of HPV infection, we find that those who are vaccinated, because they were aware of the HPV virus, that it was sexually transmitted, that as much as they've been vaccinated, they still knew they were at risk of HPV infection. This will, even in this in the current era of the COVID vaccines, we see that people think that just because they get a vaccine, then they're completely protected from said infections. However, it was very enlightening to hear these students actually speak up and say, you know what, as much as I've been vaccinated, I still know I can get the virus, but not necessarily get an infection that will result in cervical cancer. When we asked them about what is their preferred age of sexual debut, and this is mostly theoretical, a majority of the adolescents, both vaccinated and unvaccinated, selected the age group of 20 to 30 years, which was rather commendable. And in terms of how the safe practices that they would use during their sexual intercourse, most of them reported that it is always important to use protection. I know condoms do not protect against HPV, but they do protect against HIV and other STIs that can result in easy acquisition of the HPV or development of cervical cancer. For the group that had not been vaccinated, 64% of them were amenable to receive the HPV vaccine, which was quite a high number. So just a few notes that I'd wanted to bring out. We find that for most, as expected, for most of the adolescents who were exposed to the HPV vaccine, they had heard of cervical cancer and were aware of the vaccine. And this was in line with several studies that had been done on adolescents, such as in Uganda and Indonesia. And it was quite amenable, as I said, for the both cohorts to identify the risk factors for cervical cancer. And it was quite impressive, I must add, when we're doing the focus group discussions with these adolescents. They were able to draw for me a diagram of the uterus, the ovaries, and even the cervix. So they've been taught a lot in the school through their social education program. And this was quite good, because there's some women even in older age groups who cannot identify where their cervix is. So that was quite impressive. However, as I mentioned, there was a very low correlation between the HPV virus and cervical cancer, and it being that it's knowing that it is a sexually transmitted virus. And it's not just the adolescents in Eldoret. In adolescents from Uganda, Mozambique, and even Indiana in the US, they had a very low percentage that were able to correlate the two. And coming to the source of information, as I said, the school was identified as the commonest source. Only 22% would say that they were comfortable enough to talk to hospital or healthcare workers. And they really explained that every time they come to hospitals, they'll ask for condoms or they ask for any advice. Some of them would actually be discriminated upon, yelled at, and even chased away. So it shows that us as healthcare professionals, and especially for us who are interested in adolescent care, we really need to improve on this. Sometimes the hospital may not be the best environment or a safe environment for these adolescents. So we need to create the hospital as a safe environment for these adolescents. In terms of the role of media, and this is something that I would want you to share with adolescents, since most of you work with adolescents, there's an app that is downloadable on any iOS or Android device called Fight HPV. It's very interactive. It has a lot of information on HPV and cervical cancer, and it's quite fun. It has been used, it's currently being studied in Zambian adolescents, and through preliminary data has been shown that it has been very useful in providing information about HPV and cervical cancer. So in terms of acceptance of the HPV vaccine, it was very impressive to see that a lot of the unvaccinated adolescents were amenable to accepting the vaccine. But still, when we compare our adolescents to some of the other African countries, such as Mozambique and Uganda, we still are a bit on the lower side. And this could be because of all the HPV vaccine hesitancy that we are having, not just because of the lack of availability of the vaccine. And we see that we had started picking up the the HPV national vaccination program, and our center was one of the main centers where we were vaccinating adolescents. However, with COVID, yes, it came and really disrupted the program, and a lot of our adolescents were not vaccinated. Currently, we are trying to build up the momentum in terms of HPV vaccination, and we hope that soon we'll be able to vaccinate a great number of our adolescents. And so, as I summarize, we find that education on cervical cancer must be comprehensive and it must be elaborate in order to ensure these adolescents are sufficiently informed. We need to use and empower our teachers so that they can be able to ensure they are providing the correct and sufficient information about these particular diseases. Pre-COVID and as we go on back to schools, we find that our children spend a lot of time with these teachers. And so we need to use these teachers and get to tell them about these things. During this study, I had the opportunity to go to different schools, talk to the teachers, teach the teachers about the cervical cancer and HPV, and they in turn held educational meetings with the students to educate them about this. Of course, all our endeavors were cut short with COVID, but you find that the uptake just by the teachers and the students talking, the teachers talking to the students and the students talking to their family, it really improved the acceptance of the HPV vaccine when it came to the nationwide rollout. And so we really need to bring back the rollout of the vaccination and target as many students as we can. Hospital-based is not as good as school-based, but of course, once we continue to discuss about this and put things into place, I'm sure these are things that can be sorted out. I want to thank you for your attention, and I hope you've garnered something from this talk.
Yeah, thank you very much, Dr. Anissa, for that enlightening presentation. I think our work is cut out, and we need to go out there. You can see what adolescents think of us when they meet us in the hospital. I think we need to move to the community, and this is where the holistic handbook from the Ministry of Health will come in also handy. So our next presenter is Dr. Valerie Mwendwa. Dr. Valerie Mwendwa is in the Ministry of Health, the NCD unit, and she is going to talk about this emerging huge burden of NCD among the adolescents in our country. What is the implications for the adolescents and also for the youth? Welcome, Dr. Mwendwa.
Thank you very much, and sorry, the first issue is that it's not a she, it's a he. Good afternoon, everybody, and thank you very much for this opportunity to share with you briefly on this very key topic this afternoon. And I work with the Department of Non-Communicable Diseases with the Ministry of Health. So I'm going to discuss with you the non-communicable disease as an emerging epidemic, not just globally, not just among adults, but also for adolescents and the youth. So that's the that's the outline of this talk. I'm going to share with us why this matters, focusing on NCDs among adolescents and the youth. I'm also going to discuss risk factor prevalence. That's the NCD risk factor prevalence among the youth and adolescents. We're going to also look at the non-communicable disease conditions profile among adolescents and the youth. We are going to also examine the vital considerations that are required as we plan to tackle NCDs among the youth and adolescents, and also share with you a few things that the ministry and the entire the department and the entire ministry are doing to respond to the NCD burden among the youths and adolescents. Next. So this is a question question that arises anytime people hear somebody trying to discuss this topic, NCDs among adolescents. So they come in with a question: do adolescents suffer from NCDs? Most people think that NCDs, or non-communicable diseases, or sometimes called NCCs, or non-communicable chronic conditions, are diseases that affect older people. People who have live their lives, and they're in their sunset years. So when they hear this term being associated with adolescents and the youth, then to them is actually a misnomer or a mistake. So I ask again within this forum, do adolescents suffer from NCDs? And unfortunately, the answer is yes. Next. And unfortunately, it's not just adolescents and the youth suffering from NCDs, but it's them carrying a much bigger burden if you compare them with adults. And some of the factors that make this the case are shown in this slide. So one of them is that most NCD risk factors take root in adolescents. We all of us know that in most cases, alcohol and substance use starts in adolescence, and youth, that's between the age of 20 to 24. Also, we know that tobacco use also starts during this age period, and that's the reason why tobacco companies, target the youth and adolescents for initiation of both smoking and tobacco use. We also know unhealthy diets, they also take roots around this period in life. And also, if you look at, even marketing of some of these unhealthy diets, they specifically target this age demographic. And we also know, even issues, even attitudes towards physical activity, they also take root around this period. That's number one. The second thing is that some non-communicable diseases actually have a higher burden in adolescents. And this, for instance, includes injuries. And we know that actually injuries are the biggest cause of death among people aged between 19 and 24 years old globally. We also know something like type 1 diabetes essentially affects majority adolescents and the youth. We also know some cardiovascular conditions like rheumatic heart disease. The higher burden of disease again occurs among this age demographic. But unfortunately, this same age category is affected with what we tend to call these days a quadri burden. So when we talk about non-communicable diseases, you hear terms like double burden of disease, you hear triple burden of disease, but in adolescents it's something even worse. It's quadri burden. And the reason as to why this is the case is, first of all, we are seeing these adolescents and the youth suffering non-communicable diseases themselves. But they are also being exposed to risk factors that will make them suffer even more non-communicable diseases in the coming decades of their lives. And because of this, they tend to even as we move along, they will end up carrying a bigger burden of the premature death from non-communicable diseases if you compare them with adults. And definitely, if you put all this together, then it means a much higher socioeconomic impact for them. If even before, they stand on their 2 feet, even before they become independent human beings, they are already suffering from NCDs, or they are, exposed to NCD risk factors, then it's a major, major burden for them, as they progress on in life. Sorry, I don't know what happened there. Okay, and I love these, this image that we use so much for advocacy in our department. And as you see, it's starting with the first picture there. It's known that we seem to be evolving. People thought evolution stopped, but we seem to be evolving, and most of us can agree that our current stage of evolution is pushing us towards the very last, human there in that photograph. We also know that, we are doing more sedentary work, we're becoming bigger as a result, and our gadgets are becoming smaller. We do know that the burden of tobacco is substantial in our country still. We've made some, gains. We've achieved some results. We've scored some victories, but, the tobacco industry remain, a formidable force in this country. We do know that, alcohol intake in this country is a major issue. And again, I'm going to show you some figures. It's a major issue also among the youth and adolescents. We do know, looking at one of our commonest modes of transport at the moment, we know, the kind of risk that it pertains to the youth and adolescents, and to just confirm to this forum that injuries are considered part of non-communicable diseases. We do know that our diets are changing. We are seeing more and more joints that offer some types of foods that a few years ago were alien in our societies, and they're increasing. At the moment now, they're even moving away from urban centers to even smaller centers, which fit into a more rural setup. And as I've mentioned about tobacco there, we are seeing some newer products be brought in the market, disguised as even sometimes pharmaceutical products, to try and make people stop smoking. But essentially, they are aimed at recruiting the youth into tobacco use. And you can see, a product there called Lift. And if you've been following the news in this country in the last 6 months, you know more about this product that the ministry forced the industry to pull out of the market in the last quarter of last year. And so these risk factors then looked at, in terms of the quantitative aspects. We do know that from our last youth survey for tobacco use, we know that the overall tobacco use among the youths is around 10%, with the boys having a higher prevalence of use there. But the girls, they're also following closely there. And the interesting fact here is if we compare the prevalence of tobacco use among girls and among women, older women, it's much, much higher among girls. Meaning that even as you move forward, as you tackle this tobacco epidemic, we need to recognize that we are having more and more women picking up smoking and tobacco use. We also have another aspect of tobacco exposure that we call secondhand smoke. That means being present in a home that somebody is smoking. And again, a whopping 24% of, now this is global, not just the youth or adolescents, but 24% of homesteads having somebody smoking, meaning people exposed to secondhand smoke. We also have alcohol use there, boys much higher there, that's 9%, but again, girls following closely. And if you compare these figures among adults, it's very, very different. We see a big difference between the genders. Again, obesity, looking at the whole continuum below 20 years, around 4% of boys fitting the definition of obesity, and girls again around the same figure. Looking at insufficient physical activity, this is for that's each category there, and this is figures for this country. For ages between 11 and 17 years, we see boys are nearly 90%. They do not attain the recommended minimum physical activity, and again, girls following closely there with around 82%. So then, have you looked at the risk factor profile for the country? What about the NCDs themselves? And this slide is looking at the Ncd profile among adolescents and the youth using DALYs. And as you know, DALYs, it looks at how prevalent a certain condition is. So this may not point at the severest of conditions, but it's the most prevalent conditions in those age categories there. And maybe quickly looking at the two lists for the 10 to 14 years and 15 to 19 years, I think to me what comes out very clearly is the importance of mental health there, seeing that a number of conditions that fit into mental health appear there. For 10 to 14 years, we're seeing the conduct disorder, we're seeing anxiety disorders, we're seeing major depressive disorder as well. And again, for 15 to 19 years, the same conditions come up again, major depressive disorder, anxiety disorders again, and conduct disorder. And this is a key thing. Again, remembering that mental health is part of the NCDs. A few years ago, it was properly added as part of the NCD control global agenda. And we are happy that in this country, actually, mental health is actually at the moment institutionalized under the Department of Non-Communicable Diseases. And then if we take the slightly higher age bracket of 20 to 24 years, then injuries and violence come in very strongly there. So this is a profile. We do know that most of these are not fitting within our traditional view of NCDs, and this means that we need to give special attention to NCDs among adolescents and the youth. Yeah, and that's a surprise. So not the big four. All of us, anytime NCDs are mentioned, we always think about the big four, or the big five if you want mental health. So we have the cardiovascular diseases, cancer, the diabetes, the chronic respiratory diseases. But as you've seen, the profile for adolescents and the youth is a bit different, and that calls for a targeted response. And just like NCDs in adults, NCDs among adolescents and the youth is very, very complex. And I'm not going to make an attempt of going through this entire conceptual framework, but we need to understand that NCDs is something bigger than the individual. It extends to the community, it extends to the society, it extends to many other aspects that are not primarily or traditionally health. And that's the whole focus of this framework here. That for us to be able to counteract the risk factors, for us to be able to counteract the NCDs themselves that occur in the age category of adolescents and the youth, we need to have, what you call holistic approach, having policies that are cross-cutting, that are touching on education, that are touching on water and sanitation, that are touching on safety, that are touching on infrastructure, that are touching on agriculture. It's not just a single focus that will assist us to win this battle to reduce the burden of both risk factors and also the NCD conditions among the youth and adolescents. And so we do know that at the moment, as a country, our NCD care is a bit unresponsive because of a number of reasons, and they're listed there. But key among them is that our services are not children and youth friendly. As I mentioned earlier, most people don't think actually NCDs can occur in adolescents and the youth. And even the way our care is structured in our healthcare system, it doesn't have that provision for offering this kind of services to adolescents and the youth. A very good example is understanding that we have a whole bracket of an age group that is not properly taken care of by our healthcare system, people between the ages of 12 to 19 that are not properly considered under pediatrics and also are not properly considered under adults. And if you go, you find that some facilities, they admit children in the pediatric wards up to the age of 12. And then the other, that other bracket there is not clear where they're supposed to go. So most of the time they end up in adult wards. So our system, our NCD control approach is, at the moment I can say, is not children and youth friendly. And I think among these other things, that's the reason why, our approach is not very responsible. So there are many front lines of the NCD war. Sorry for using the, the military kind of language. But among all these, focusing on the youth agenda, and again, in a very holistic way, in a very cross-cutting way, in a very collaborational way, forging effective partnerships is the only way we're going to reduce this burden. And unfortunately, if we are not able to achieve this, the only thing we are doing as a country, we're postponing the problem to later years. Because as we see, most of the issues that we are supposed to be addressing now among the youth and adolescents, they will manifest as NCDs many years, even decades from today. So if we don't address all these issues, you're just postponing the problem that can make this country not achieve its own economic blueprint, in addition to having the other major health impact. Next. And so we, at the moment, we are focusing on what we call a whole of life approach to NCDs prevention. As I showed on the conceptual framework to NCDs among the adolescents and the youth, these are not conditions that just affect the individual. They are cross-cutting. And for us to be able to be responsive, we have to respond in the entire life course. And as you see there, mothers and infants, we do know that some NCD risk factors starts as early as in utero. So we need to intervene there. We need to intervene among the younger people. And of course, we need to intervene among adults and the older people as well. So it must be an intervention that is cross-cutting in the entire, life course. And again, including all the array of all the key risk factors and the key and non-communicable disease conditions that we've noted earlier. I want to mention here as I come to the end, some emerging trends that we believe as a department we can focus on and we can ride on. One of them is devolution, and devolution in this country has had its fair share of challenges, but to look at it as an opportunity to bring services closer to the people, making services responsive and making the system itself responsive to the needs of their particular populations. The second thing is universal health coverage, whose discussions, I understand, are moving to the final stages. And the good thing here is focus on primary health care and the community health strategy. And we feel NCD care, risk factor control, awareness, screening, and management can actually be organized at the community and the primary health care level. Of course, we do know we are in the middle of a pandemic, and it has changed a number of ways, how we offer health services and how we plan for them. We believe as much as it has caused disruptions and interruptions, it gives us an opportunity to rethink our healthcare system so that it's more responsive and is more patient and individual-centered. We also are so strong on collaboration, and an example that we've been able to forge collaborations with is National AIDS Control Council. We do know for the HIV control world, they have very good systems created already in this country for reaching the youth and adolescents, and we do believe we can be able to use similar platforms to preach the message on NCD and NCD control. We also do know, intervening in child health, reducing things like childhood obesity, focusing on childhood cancers, which is a major focus now, and also type 1 diabetes in children. A key issue about mental health in NCDs, not just in youth and adolescents, but also in adults. There are two aspects. We have mental health itself as an uncommunicable disease, and we also have mental health among adolescents and youth living with NCDs. So we need to focus and handle these two emerging issues together. And then, of course, access programs to improve on availability of essential medicines and technologies. NCDs as conditions are very expensive to manage and to treat. And I'm happy to report here, we don't go into detail, that there are a number of access programs that have been achieved in this country, for instance, in type 1 diabetes, and also we are following up on childhood cancer. So a summary of the Kenya country response, what has been going on in the last couple of years and at the just expiring national NCD strategy. So one of them is an adolescent comprehensive risk factor survey. This was done by our department, our sister division of adolescent health, and we understand the report is being finalized. We should be able to share these findings soon. We also have a renewed focus on mental health, and I think most of us have seen this across various fora. And currently, as I mentioned, mental health is institutionalized under the Department of NCDs. We also have risk factor control, and we have key notable achievements as a ministry in tobacco control, including legal win against the industry last year or last quarter of 2019, and we're implementing some of the additional provisions of the Tobacco Control Regulations 2014, and also integration of adolescent health services in routine services. We also are doing quite well in health promotion, screening, and early diagnosis of NCDs, and good examples here are cancer and diabetes. And also, again, and I mentioned these access programs to improve availability of essential medicines and technologies. Yes, and as I conclude, we usually talk about two possible approaches in NCD control. One of them can be, mopping the floor, and we'll be doing this for quite some time. But the other one that we think is more effective is actually turning off the tap. So we actually do believe focusing on adolescents, focusing on the youth will be a very, very good strategy for this country to start turning off the tap. Thank you very much for this opportunity to share with you the aspects on NCDs among adolescents and the youth.
Thank you very much, Dr. Mwendwa, and my apologies for the earlier mistake. You have done a great job in opening our eyes on the NCDs among the youth and the adolescent. And as you have rightly said, of course, when this NCD starts with the youth, of course, there's the burden of years of life lived with disability, years of life lost, and also disability adjusted years, of course, increases. So I think this is something that we need to look at, and it's an opportune time. So to take us to the next level, because one of the issues that brings this problem of NCD is issues of nutrition. And we know that, of course, during the adolescent, this is a period of remarkable growth, which is only second to what basically occurs in the first year of life. And this is also an area where if nutrition is not taken care of course, it has also a lifelong risk. We are seeing a lot of undernutrition and of course, a lot of overnutrition. So I'm going to invite our colleague from the Ministry of Health, the Unit of Nutrition and Dietetics, Ms. Leila Akinyi, to present to us on why scaling up appropriate nutrition amongst adolescents is important in Kenya. Welcome, Leila.
Thank you so much. Confirm you can hear me?
Yes, we can.
Yes, I'm Leila Akinyi, Program Manager, Healthy Diets, and which tackles adolescent nutrition. I'm from the Division of Nutrition and Dietetics in the Ministry of Health. I'm also the Deputy Head of the Division of Nutrition and Dietetics. So today I'm going to talk about why nutrition matters for adolescents and why scaling up appropriate nutrition amongst adolescents is important, the Kenyan experience. And today I will majorly focus on the policy environment, but I'll give a background. So the outline of the presentation is adolescent nutrition situation, importance of nutrition for adolescents, nutrition promotion for adolescents, and the policy frameworks for adolescent nutrition. Just to create on why nutrition matters for adolescents, it's a prerequisite for national development because there is a link between the country's development and optimal nutrition for the whole population through the life course approach. Good nutrition is essential for learning potential of children. As we know very well, when we look further into the presentation, there are certain micronutrients that are critical for the classroom interaction for children. And again, if the previous nutrition in early years is not good, then the child's learning potential is significantly reduced. Children who are stunted, that is low height for age due to malnutrition, in early childhood perform lower in IQ and other tests. And also the other justification is that malnutrition in early childhood can affect enrollment, attendance, attentiveness, concentration, aptitude, and overall performance. While a child who is malnourished cannot adequately take advantage of instructional and learning materials, and you will see as we progress, even a hungry child will not also be able to concentrate in class. Nutrition education and promotion in schools has significant effect in fostering healthy eating habits. When we look at why nutrition is important in their developmental agenda using the UNICEF conceptual framework for malnutrition, we see that the outcome in this case, in this diagram, is malnutrition, but the immediate contributing factors is inadequate dietary intake and disease. And especially today, while we focus on dietary intake that could contribute to malnutrition, we are talking about the underlying cause, which is inadequate access to food and inadequate care that would make malnutrition come about. And when we look at the basic causes, why is there inadequate access to food? We find it is more about jobs. People don't have a job so that they can get money and buy food, or there's no adequate production. So those are human, economic, and organizational issues that are very basic that contribute to now the outcome malnutrition. And the political environment, ideological factors, including cultural practices, are usually very basic in the conceptual framework of malnutrition. When we look at the view of adolescent nutrition situation in Kenya. I must say, first of all, that currently we do not have data that we have collected specific for age 10 to 19 on nutrition situation. So we will look mainly at data that are related to adolescent nutrition and a few that give us a snapshot of adolescent nutrition. So when, even as I said background, before I look at the nutrition situation, we find that nutrition in the SDG is a major underlying component in all the 17 SDGs, but in SDG 2 and especially strategy 2.2, we expect that the nutritional needs of adolescent girls, pregnant and lactating women are addressed. And the other issue is that it costs, it's very expensive. Malnutrition costs African countries and their GDPs very high. And for Kenya, it is around 6.7. So when we look at the nutrition situation, right, when we are setting the background for adolescent nutrition, because these children who are 0 to 59 months will end up being adolescent at age 10, the stunting levels of our children 0 to 59 months is 26%. That is according to KDHS 2014. And we have regions in Kenya that have as high as 40 to 50, between 40 and 50%, or above 40%, counties like West Pokot, Kitui, and Kilifi. But I must also acknowledge that there has been improvement, but we will see in the next KDHS. And we have disparities in the country where some counties have very low levels of stunting, but the lowest in Kenya is 15. And again, very high level, like the way I said, West Pokot is 45%. And we look at the distribution of stunting when we relate it to the level of education of a mother of the stunted child, we find that it reduces as the level of education increases. When we looked at, we teased out this information from KDHS, and therefore there's a direct link between stunting and level of education. And this is a CAT scan of a normal child and a child who has malnutrition, severely malnourished. We find that there's actually big impact in terms of brain development. When we look at statistics around the micronutrient deficiencies, again, I will still insist that our data is not disaggregated to 10 to 19. But when we look at the school age children, so the first one, PSC, is preschool children. These are children 0 to 59 months. The anemia levels is 26% according to the Kenya National Micronutrient Survey 2011. We are planning for the next one. Then school age children, where adolescents fall, that is age 5 to 14, the anemia levels are 16%. But among pregnant women, which again we acknowledge that sometimes we have quite a number of adolescents pregnant, adolescents 15 to 19 years from the KDHS, 41% deficiency. This is for pregnant women, 15 to 49 years. So those are the levels of anemia. When we look at vitamin A deficiency, again, we still have that deficiency among preschool children 0 to 59 months. Zinc deficiency, we will look later at the importance of zinc to adolescents across the population, right from preschool children, school age children, pregnant women and men. Zinc deficiency is above 60 to 70%. So the entire country has a big problem of zinc deficiency. When we look at the extreme right end of the presentation, that is the totals among the different categories. So like when we look at among men, it's around 65%. Among non-pregnant women, that is 15 to 49 years, is around 81%. So when we again look at disaggregated data from the National Micronutrient Survey for folate, which is a very important micronutrient, and vitamin B12, Among women of reproductive age 15 to 49 years, the folate deficiency is 30% and vitamin B12 34%. And B12 is very essential for release of energy and also for growth and development. Same to folate, especially in the early years of formation of the child at fetal state. And when we now disaggregated the data to age 15 to 19, which is adolescents, again, the deficiency is 31%, and for vitamin B12 is 47% for girls, for 15 to 19 years. Again, we do not have disaggregated data for adolescents, but we have data for obesity and overweight for women age 15 to 49 years, and 33% are obese. And when this data is disaggregated, we have found regional disparities where the counties in the central area, that is Kirinyaga, Kiambu, and Mombasa, and Nairobi, the obesity levels, overweight obesity is above 40%. So that is what this slide is about. And we also find the prevalence of overweight and obesity among adults, both men and women, is 28%, but when disaggregated among women, it is high, 38%. So when we look at for nutrition, we have the underlying cause of malnutrition as I presented in the conceptual framework, and we look at the practices, dietary practices among our population. So I will present some data that demonstrates the dietary practices right from birth up to adulthood. So we find that the exclusive breastfeeding is 61%. And remember, I mentioned that there is a direct link between the IQ levels and feeding practices, especially exclusive breastfeeding. So we are at 61%. And when we look at complementary feeding among children 6 to 23 months, only 22% of children 6 to 23 months consume an acceptable diet. So these are proxy indicators to show the dietary intake at family level. And when we compare the practices in terms of consumption of acceptable diet and the level of education of a mother, again, you find that the more educated the mother, the better the feeding practices. Again, this is something we teased out from KDHS. It is important to discuss issues around that so that we see the platforms that can make us improve significantly on nutrition and dietary practices. For data around the adults 18 to 69, this is from the stepwise survey on risk factors for non-communicable diseases. 95% of adults do not consume the recommended 5 servings of fruits and vegetables. Only 5% get the recommended servings. And when we look at the vegetables consumed, only fruits are consumed only 2.5 days, 0.4 days in a week, and vegetables 5 days in a week. So this is very important when we are talking about NCDs, cancers, and overweight, obesity, and such discussions. So when we look at the nutrient needs and the nutrition around adolescents, the uniqueness and why we discuss adolescence is because of what they are going through. As the one who introduced me said, this is a period of rapid growth and development. There is increase in the skeletal and endocrine in terms of growth. There is growth and sexual the maturation of the sexual organs, and therefore specific nutrients are critical for these particular growths. Like I'm showing, zinc is very critical for growth and sexual maturation, and iodine for growth. Vitamins, especially B12, as I highlighted earlier, and folic acid is critical to release energy and for growth and sexual maturation, and many other nutrients, which I wouldn't emphasize on, but calcium there is very critical again for skeletal and endocrine growth. So when we look at the specific nutrient needs, this is a table that shows the school-age children right from age 4 to age 18, but now the part highlighted yellow, blue, and purple are the ones showing the nutrient needs for adolescents, so that we appreciate how much. And we notice that, look at the carbohydrates, it increases significantly from the lower stage of adolescence 10 to 14 to the higher stage, where boys now, the lower age 10 to 14 was 316 grams per day. And then when they are in, boys in secondary school, they now need 460 grams per day. The other one I need to highlight is energy, the kilocalorie needs. Look at the difference between the secondary boys, this one, 3,200 kilocalories, and girls 2,400 kilocalories. So again, when even the children are in secondary school, and most of them are in boarding schools, are they getting adequate nutrition? The other one I will highlight before I move to the next slide is vitamin C at the extreme right end, where we see a big difference between needs of boys and girls, 15 to 18 years. So we look at food. The food gives us nutrients, and it gives us macro and micronutrients in different types and forms and functions. So we have to talk about food. And we go ahead in nutrition to categorize food in a manner that will tease out the nutrients that we need from the foods. So we have disaggregated food further into smaller categories. We no longer talk about balanced diet, but we talk about a healthy diet where you really have to try and combine as many food groups as possible. And these are the examples: grains and grain products. Then we have legumes and pulses that give us very specific and unique nutrients. Nuts and seeds give us very specific and unique nutrients, dairy and dairy products. Then we also have meats. Then we have, in the vegetable category, again, we have broken them down into orange and yellow fresh fruits and vegetables that are rich in vitamin A. Then dark green leafy vegetables are rich in iron and also vitamin A. We have categorized them as a food group on their own. Then we have other vegetables and other fruits. And that serves to give us why we need to concentrate on food groups for women of reproductive age and children 6 to 23 months. So in terms of messaging, we encourage people to eat variety in terms of 4 to 5 food groups in the eating plan daily. Portion according to age and gender, and we can see we are talking about adolescents. It should be enough, not too much, too little. Dense in terms of choosing the right type of food that will give you the most nutrient, but with the least food energy, so that we do not overconsume in terms of energy. Moderation and safety in production. So these are the messages we use. One of them is eat a variety of foods every day. That is what we say, try to vary. That's why we have put the food groups there. Then you can unpack it further by giving them specific messages like eat green leafy vegetables, red and yellow fruits and vegetables, and a variety of other fruits and vegetables. That way we are picking out colors of foods that can make you know this, when we pick this color, it gives you this particular nutrient. So these are just examples. You can also look at the presentation when I finish. We expect the adolescents to drink milk daily, and then we don't refuse the use of salt, but use it sparingly. Sugar, we just say if you use sugar, because whether you use or not, it's nothing wrong. So in terms of the Folic policy environment, we have the Food and Nutrition Security Policy, then we have the Nutrition Action Plan 2018-2022. In the school Ministry of Education, we have the school meals strategy, and we have the homegrown school meals program. We also have the school health policy, where we have nutrition as a thematic area. We also have the, I've talked about these ones. Then for the adolescent nutrition interventions, the reason why I'm rushing through, I may not be able to explain in detail what are in these documents, but in school meals, we are very clear on guidance on school meals. We have a menu guide for schools. I will explain that in the later presentation. School nutrition, which is pegged in the school health program where Dr. Ann is, we have a thematic area of nutrition, and we have a mainstream nutrition in school health. We have gone further to engage with the Kenya Institute of Curriculum Development and mainstream food and nutrition content in the ongoing reform. And now we are developing a reference manual because our content is already in the school curriculum, being articulated in the classroom. We have an adolescent nutrition technical working group that meets monthly. And in the food and nutrition reference manual, because this is work that is ongoing, we have mainstreamed nutrition in the curriculum, and we have a reference manual for teachers. We will distribute this manual to all the schools. The topics are principles of nutrition, nutrition in the life course, meal management, nutrition-related disorders, and all that. And why I'm mentioning this, we had multi-stakeholder engagement when we were mainstreaming nutrition in the curriculum. We really put in health, we put non-communicable diseases, we put WASH inside. So this process is ongoing. So any stakeholder who is interested, we are working very well in the Ministry of Health to mainstream nutrition in the school curriculum. Some of the adolescent nutrition documents we have are these ones. We have a facilitator's guide, and we also have a job aid, like a counseling card for adolescent nutrition in Kenya. Thank you very much, and over to you.
Thank you, Rada. That was very enlightening. And as we can see, this workshop came at a very opportune time because you can see the burden that we have, undernutrition, overnutrition, then our adolescents get into early marriage or get very early pregnancies in this situation. So the outcome of these pregnancies become even more guided. So I think this calls for the targeted response, a multi-sectoral approach, and we try to achieve all the SDGs so that we can bring up a healthy population right from childhood all the way to old age. Thank you very much. I think we have come to the end of our presentations. The presentation on vaginal practices from the team in Mombasa, as well as the presentation of FGM from the team from the North Frontier region, that is Hassan, will be presented tomorrow. So I will invite my colleague and co-presenter, Dr. Joyce Wamishwe, to take us through the next part, which is the question and answer session. Joyce, over to you.
Okay, thank you so much, Professor Wanyoro. You've been an excellent co-chair in this session. And the presenters, from what I can see in the Q&A and even the chat, the attendees are really impressed by the work that you have presented. You have shared a lot of new information. We are hearing buzzwords like multi-sector, multi-stakeholder, holistic. We had quadri burden when it came to things to do with NCDs. And we have quite a number of questions, which I will request presenter by presenter. I'll let you know which questions you have been asked to you. And then we also have people who have been raising their hands. So once we've done the Q&A, what was being posted, we will give some time to the people who have their hands raised. So we'll quickly start with Dr. Anne Mwangi. You had two key questions. So one of them was, where can one access the school re-entry policy? And then have you included the aspect of how social media and internet access can be used to promote the health and well-being of adolescents so that they become helpful rather than destructive tools? And then there was one medical colleague who was, I think he's really stressed by all these teenage pregnancies that are happening. So there was one general question that was, what can I do? How can I be involved in reducing these teen pregnancies? And then lastly was a great input from my co-chair and also from an attendee about the cover of the booklet that you presented. Perhaps can we try and consider having a more inclusive picture on the cover so that we can be able to demonstrate the three partners that you talked about, that is the adolescent himself or herself, and the parent or caregiver, and the community leader. And we ensure that we're able to show both sexes. So over to you, Dr. Mwangi, so that you can respond to those questions. Thank you.
Okay, thank you very much, Dr. Joyce Wamishwa. I'll start with the first question, which is on where one can access the school reentry policy. I want to believe it should be in the Ministry of Education website, but in case it's not, I have a PDF copy, which probably I would share with the person who wanted. Maybe they can just send me their email address. I could share with them the copy. The other question is around the use of social media and internet. We did mention that, but mostly we focused a lot on safety on the internet, what the parents need to know and what the adolescents need to know. In regard to the question on how the person can get involved, this document is going to be available. We are launching it in May next month, and as long as someone is working in the adolescent space, they can utilize the document to have a conversation with adolescents at whatever level that you work, even if it's in a hospital, even if it's in a clinic. It will help you because it is more of an interactive document. You can actually initiate whatever kind of a conversation you want to initiate with the adolescents if you are working in the space of adolescents in whatever, whether at the community level or health facility level, especially where we even have support group settings, it is still possible to utilize the document. The other one is the comment I got from the co-chair, and like I said, the document is final. We have it even has been signed, but it is still possible to work with the person who did for us the graphics to adjust that, because we've not gone to the printers as yet. So that comment is taken very seriously. We are going to see how that can be adjusted. There's a question also on whether we have included penalties to boys or men who impregnate girls. We reference the existing laws in the country, so we didn't put what penalty is done, because as I said, as long as the community leaders are aware that they need to reinforce the laws and the regulations in the community, then they should be able to deal with the perpetrators of whatever injustices are done to the adolescent girls, not just to girls, but also to boys, because we know that even boys, as we have had in this forum, I think yesterday we had a presentation on sexual violence, even boys are actually also survivors of violence, whether sexual, physical, emotional, or other forms of violence. And so the document does not just address the girls, it also addresses the boys. So those ones should, the parents will also be, the parents are also, in the parent content, they have also been enlightened on what to do in case they suspect that their child is getting abused sexually or otherwise, and what not to do, because we also know that some parents clean up their children, and what to look out for. So basically those things are in the document. Thank you. I think those are the comments. If others arise, I'll address them as they come. Thank you.
Okay, thank you, Daktari, for that. Well put. So now we go to Dr. Odongo. Enlightening presentation. And one of the things we learned was we need to look for these tumors. We need to look for tumors that we previously thought are only found in older women. They're also being seen in the younger age groups. And so instead of people poking to deal with ascites, we need to refer appropriately. So there were several questions, but one of the questions that keeps on coming is, how do we screen adolescents for these tumors? What tests can be done as a routine examination for early detection and treatment? I think I've seen that question several times throughout the Q&A. The other question was where fertility sparing surgery isn't possible, depending on the type of tumor. Do we do things like oocyte freezing so that the girl has future fertility options? And so is that option there? And then there was a 9-month-old that you showed, and what was the probable factor for the condition that the 9-month-old had? And then what are the predisposing factors for the gynecological cancers among our young population? Over to you, Dr. Odongo.
Yeah, I'll answer them. I'll try to be brief in answering them. The first question is about screening for gynecological malignancies. Well, it depends on the organ that is involved. And before we talk about developing a screening test, we should adhere to the WHO principles of screening. And this includes the fact that the disease has a significant public health burden. The second one is that the disease has a very long latent phase, whereby you can institute treatment of pre-malignant conditions and sort of arrest the spread of the disease, and of course, the availability of those tests that are sensitive, specific, etc. And among the gynecological malignancies that fits this criteria is actually the cervix, because of the long latent phase, and it's fairly accessible to do cervical cancer screening. So among the gynecological malignancies, what we can really screen for is cervical cancer. And there are many methods of screening. And I know the government now is moving towards HPV DNA screening. And I believe that's where we should move to also, whereby we use HPV DNA screening as the first test. And those who have high-risk HPV DNA are subjected to colposcopy and biopsy of the lesions, depending on what we find. Those with negative HPV DNA, then practically, they're not really at risk of developing the disease. I know some tests have been developed elsewhere for screening of ovarian cancer. Ovarian cancer has been noted as a silent killer because many times it is really not, you don't feel anything. It is asymptomatic. And from our data, most of our patients are actually at stage 3C disease, especially for the epithelial types. But for the germ cell tumors, because this is found in younger children, most of the time the masses are discovered by the caregiver or the mother, and they tend to come to hospitals early. So the screening test for ovarian cancer does not really fit into the WHO criteria, but that's notwithstanding, we have got tests like OVA1 that are not really specific. But if you find a child or an adolescent with an adnexal mass suspected to be ovarian, you can do two things. One, you can image by ultrasound scan. And upon imaging, there's some appearance you look at on the scan to tell you whether it's malignant or suggestive of malignancy. It's called, like, for example, if they are bilateral, means they are on both sides, or there's presence of ascites, or there is presence of multiloculation and solid and cystic areas. Then you start suspecting maybe there could be a problem. Then in this case, we also do what we call the tumor markers, because this ovarian tumors, especially the germ cell ones, they elaborate particular tumor markers. For example, alpha fetoproteins for yolk sac tumors, beta HCG for choriocarcinomas, and LDH for dysgerminomas. So you can be able to tell and screen like that. Let me just mention something called about risk of malignancy index, especially in young women. You use the levels of CA125, and then you multiply with the ultrasound features, then that can also tell you whether you're dealing with a malignant disease or not. That's part of the screening. Just to go to the gestational plastic neoplasias I mentioned, you follow up with beta HCG. So if a woman has a pregnancy that's suspected of a molar pregnancy, don't just send them away that after evacuation, but you follow up with beta HCGs so that is whether it is rising, falling, or plateauing, and act appropriately. For abnormal bleeding in adolescents, always investigate. I know most of them is maybe as a result of foreign bodies that they have put inside, but always check whether there is something else. Regarding fertility sparing surgery, yeah, it's a good question. First, there is no role of, let me say, radical surgery in patients with suspected germ cell tumors because they are chemosensitive, and these patients are usually young women. But for epithelial type, then the survival depends on how much tumor you leave behind. That is on the degree of debulking. The better the debulking in terms of complete debulking improves survival. And if a patient has epithelial cancer, then there is no role of sparing the fertility. The idea is about optimal debulking. And this brings me to oncofertility. Yeah, it's gaining traction, whereby women can have their ovum stored. It is now available in the private sector. And the issue is about what we should think about the law of the land. I don't know, it's really clear on how long we should store this ovum, because you can store them for pretty long, for decades actually, and it's stored at -70, but the charges, the last time I checked in the private sector, is close to around 40, that's 4,000 USDs for storage. The 9-month-old, yeah, that was a granulosa cell tumor. Most of them are sporadic, but some of them have got some mutations. Just to mention it here, not going into details, I've got the FOXL2 mutations, which leads to production of, it's actually a missense mutation, production of abnormal proteins. And also maybe if Anissa can mention more about the DICER1 mutations for granulosa cell tumors. What was the other one? I think I've answered most of my questions. I think so.
Yes, Daktari. Yes, and thank you for that. As I said, one of the attendees actually said it's a great presentation, eye-opener by the MTRH team on management of PV bleeding, especially amongst adolescents and malignancy management. So keep it up. So next we went to Dr. Anisha Mburu's presentation. Very thoughtful, very insightful presentation. Source of information when it comes to vaccination amongst adolescents was actually the school. Then issues to do, what we keep on hearing, adolescents don't want to come to hospitals because of our attitude as healthcare workers. I think we also had something similar from Dr. Valerian Mwenda. So Dr. Anisha, I know, has responded to several of the questions that had been put up in the Q&A, specifically to do with, is the vaccine available for free in our hospitals? And she responded that it is free for 10-year-old girls in designated health facilities, government health facilities. Where did she get the source of data on the decline in age of sexual debut? She got that from the Kenya HPV Fact Sheet 2017. So Dr. Anisha, I would like you to respond to three that you haven't responded to. So one is about people asking about boys, should they also receive HPV vaccines? And they're younger girls, less than 10 years, can they also receive the vaccine, or it has to be from 10 years only? Then what are the statistics on cancers in men resulting from HPV? And then I would like you to touch on what are the suggestions on reaching adolescents who are not in school and who do not have access to digital platforms? I know for this latter question, you have answered it, I mean, on the forum, but it's something that I think would be good for all of us to hear you talk about. Over to you, Daktari. Thank you.
Thank you so much for the questions and for the opportunity to respond. I'll start with the first one about the gender in terms of vaccination. Yes, absolutely, we need to vaccinate boys. And we see for the boys and the men, they tend to develop even the cervical cancer causing viral HPV serovirus, such as the 6 and 11 that cause the genital warts, and they are also at risk of developing penile cancer. And for those who participate in men having sex with men, they tend to have anal cancer. And we know that with our current generation, there's also a lot of anal sex. So it's something that can be seen in both men and women in this generation. So for boys, they need to be vaccinated as soon as they can, as availability comes to them. The WHO currently recommends the minimal age to be 9 for both of the girls and the boys. And the best age group to be vaccinated are 9 to 11, according to the WHO. However, there's been some caveats of up to age 26 who can be successfully vaccinated. After that, the response to the vaccine and the ability for it to prevent cervical cancer becomes well diminished. And so the effectiveness is not as good as you would have it in the 9 to 11-year-olds. So the reason why we still vaccinate boys is because they still are the harbingers of this virus, and they transmit it to the females. And now, apart from, yes, penile cancer, anal cancers tend to be rare, but they are increasing in the recent, there's a survey that has been published, I think, internationally over the last 10 years on the trends of anal and penile cancers. And the trend is going upwards. So they still are at risk. And there's also the fact of herd immunity that is developed for all the people who are vaccinated, such that in the long run, it leads to, what's it called? Ability or immunity against the virus that is spread for everyone who's vaccinated and leads to a long-term cervical cancer control. This has been well established in Australia since it was the first nation to start vaccinating boys. So it's something that we need to consider. Yes, due to finances and availability, Kenya only is vaccinated 10-year-old girls. It doesn't mean that they're the only ones who are eligible. So there was a question about a 6-year-old, and it's not recommended for anyone less than 9 years old. So in terms of reaching these adolescents who are not in school, who don't have access to digital media platforms, one thing that has worked, especially in our center at MTRH, is the Adolescent Center. So this center has been set aside from the main hospital, so the youth can walk in, incognito, so to speak. They don't have to interact with other people. They have their own gate, their own pathways to it. This gives them a sense of anonymity. And these adolescent centers also are available to street children. And so it is open to anyone who wants to walk in. The staff has been specifically trained to deal with adolescents. They talk their language. They're able to see them without any judgment. And so we have a lot, especially the street kids, they just walk in and they know they can get the services they require, be it HIV, be it contraceptives. They feel very welcome. For those who do not have the ability to come to these centers, we need to talk to the community healthcare workers and the community healthcare volunteers. They, in whatever region they're operating at, they have access to the adolescents. They actually know where they are. And some of the adolescents will actually even know some of them. So they have been very instrumental in reaching out to these adolescents. And so there's people who we need to educate more and give them the sufficient knowledge in terms of preventive services and even directing these adolescents to the adolescent centers. Any more ideas are welcome. I'm hoping I got all of them.
Yes, Dr. Yes, you did. And thank you for that. One of the things I got from your presentation is that when we start doing the COVID-19 vaccination amongst this age group, the school angle will be very important. So I'm here asking myself, we know how many teachers have been vaccinated so far. So are we able to estimate the vaccine hesitancy amongst the adolescents if it's the teachers who we are going to be using to communicate about the advantages of getting the COVID-19 vaccination? Anyway, so the next presentation was Dr. Valerian Mwendwa about the Ncd, the emerging epidemic. he indicated adolescents do actually get NCDs. He talked about the quadri burden and talked about the need for a holistic approach that also goes through a whole life approach. And then he asked us, are we going to be turning off the tap, or do we want to continue mopping the floor? So one of the attendees actually has commented, Dr. Mwendwa, this one is for you, and said that was a very pregnant presentation. So the questions that have come through are actually two. So how do the risk factors for NCD vary by socioeconomic status? And to what extent is your team at the ministry engaging with other ministries to ensure investments in infrastructure that support active lifestyles, like public playgrounds, sidewalks, and issues to do with increasing road safety? So over to you, Dr. Thank you.
Thank you very much for those questions. And for the first question on risk factors, it was very interesting for us when we did our first non-communicable disease risk factor survey in 2015, the stepwise survey, that we expected to see some differences in some of these risk factors, and even the NCD conditions themselves between, either wealth strata or socioeconomic strata, or even rural urban differences. Traditionally NCDs have been viewed as, conditions of the wealthy, people of means. But unfortunately, that was not our findings. Actually, if you look, and I think I can be able to share the STEPS report with the team, most of those indices, there are no major differences between various NCD risk factors or targeted NCD conditions in that survey between various wealth quintiles. We look at 5 wealth quintiles in this country, and also between rural urban areas. That we also know there's some aspect of socioeconomic status between urban and rural populations. So the differences are not big. Actually, in some things, like in some age groups, even something like obesity and overweight is actually slightly higher in rural populations than in urban populations. And I think this is, as a consequence of what we're seeing, what some people in some quarters are calling urbanization of the rural areas. That's, the lifestyles and many aspects of urban life can actually be seen in the rural areas. It's very difficult, other than maybe just the demographic setup itself, to see a major difference in the way people live and carry out their lives between rural and urban areas, and between different socioeconomic strata. On the second question about how we engage with other ministries, as I mentioned in my presentation, NCDs are very complex conditions, and they are very cross-cutting. These are not conditions that you can just focus on health aspects. To be able to achieve this, we have what we call the Non-Communicable Disease Intersectoral Coordinating Committee, or what we call in short Ncd ICC. This entity is a cross-cutting entity that brings on board all Ministry of Health relevant units, other aligned ministries, civil society, the academia, basically all actors in the NCD control space. They are brought together under this umbrella, and it's actually coordinated by both ministry and non-ministry individuals. And under it, we have various technical working groups, and this is how we drive the NCD agenda in this country in a collaborational approach, so that all of us are doing it together, not the ministry doing and then the civil society and academia being on this other side. We do it together, we plan together, we implement together, we evaluate together, we get the lessons and discuss them together. So that's what we're doing, and I'm happy to report here that actually we are starting to see the results of this NCD ICC, and each of the TWGs under the NCD ICC meet very frequently and share the progress that we are making. And I think I gave an example there that if you look at, because the question specifically actually talked about something like footpaths, for instance, if you look at most of the construction or road infrastructure projects in urban areas at the moment, you realize that it's a requirement for them to work on the footpaths. So that did not just come out of a goodwill somewhere. It was something that was actually pushed for as an NCD control agenda. So I hope I've responded to the two questions. Thank you.
Yes, thank you, Dr. You've done it very well. So lastly, but not the least, we had nutrition. And Leila took us through a very interesting presentation, indicated that nutrition is a smart investment. But one thing that was key is that we need to have disaggregated data for adolescents so that we can even make smarter decisions regarding this particular subpopulation. And the questions that have come up are three. So is there a requirement to fortify foods like bread, flour with folic acid and other vitamins? I know we fortify things like flour, but Leila, I think you are better placed to respond to this question. Then what is the difference between healthy and well-balanced diet? Each contains requisite ingredients in the proper proportions. And then lastly, for things like what you showed, the zinc deficiency. So should we start giving our adolescents the supplements that we see being sold in pharmacies and in some high-end supermarkets? Over to you, Leila.
Thank you so much. I had tried to answer by typing, so I can just read. In terms of fortifying, we have mandatory fortification for packaged flour, that is wheat and maize, fats and oils and salt. So anything that is sold on shelves, packaged and sold on shelves in the form of packaged flours, fats and oils and salt must be fortified. And I also said that fats and oils are fortified with vitamin A, while flours, the wheat and the maize flour, have 7 to 9 micronutrients, including vitamins, iron, and zinc, and salt is fortified with iodine, and that is what we have in fortification. The other question about supplementing, the only exploration we have guided by WHO is supplementation with iron folic acid for adolescent girls. The strong recommendation from WHO is that any country with anemia levels above 40% should consider strongly supplementing girls, adolescent girls, with weekly iron folic acid supplementation. So at this time we are exploring, we have tried a pilot in terms of implementation, and we are exploring putting a policy guideline for giving supplementation of iron and folic acid. But any other supplementation at home is not recommended. We usually expect a doctor to prescribe supplements based on diagnosis, and the diagnosis must come from biochemical assessments on the level of micronutrient deficiency. The specific micronutrients are prescribed for a specific period of time. On the question of balanced diet versus healthy eating, of course, we wouldn't say we are really dropping the word balanced diet or a well-balanced diet, but what we mean is previously when we were growing up, we were taught about energy-giving food. We have 3 food groups: energy-giving food, energy-giving, protective foods, and bodybuilding. But now we have opened up the way I presented in the food groups, that you try to eat a variety of food groups every day to meet the needs. And of course, when we are doing nutrition education and counseling, now we can unpack on the servings and how much per meal, so that someone is able to achieve. So you can use well-balanced, but you have to say well-balanced means that you're eating a variety of food groups, at least 4 to 5 food groups every day across the 3 meals of the day, and keep changing the food groups. It can be today you're eating yellow or orange fleshed fruits, and the next day you're eating dark green leafy vegetables. So you have to vary on a daily basis to access the micronutrients that are found in those foods. Thank you very much.
Thank you, Leila, for that. We appreciate your feedback on the questions that have been raised. I still see 2 hands. I'm guessing the other hands went down because their questions were answered during this session. So Anne Pulei, could you please ask your question, and then Gemeli. I think I'll only allow those 2. Anne Pulei. Dr. Kinuthia, are they able to mute? Okay, they have disappeared.
Yes, I have, yes.
Anne Pulei.
And Pulei.
Okay. Okay, how about Gemeli?
Did you call out my name?
Yes, Anne Pulei.
Yeah.
Yeah, kindly go ahead and ask your question.
Oh, I didn't ask any question. I think it was a mistake. I unmuted and then, yeah.
Okay, thank you, thank you. Gemeli, you. Hello?
It looks like a mistake.
Okay, so I think we've come to the end of our session. Once again, thank you to my co-chair. At the peak of our session, we were about 397 participants. I think that's a great number. And now I'll hand over to Dr. Kehara for the wrap up. And thank you to all the 397 participants who attended. Dr. Karibu.
Thank you very much, Joyce, and thank you very much, Professor Wanyoro. Even before I go to my closing remarks, I want to just recognize Waziri who's with us, Dr. Amina Mohammed, Ministry of Sports, Culture and Heritage. Thank you very much for taking time out from your busy schedule. She may be here amongst many others, but we want to really appreciate their presence and also the learning that they're gaining from us, because she has posted that to me directly. Now, I want to be a little bit provocative, and I'll start with Dr. Anne Mwangi. Community health volunteers, and mark the word at the end, volunteer. And in this day and age and dispensation, and also from the research we've been conducting for almost 5 years in the field of immediate postpartum IUD insertions, we learned certain lessons with the community health volunteer. One was attrition. You train them, give them the training package, they simulate and actually get what you need to have taught within the communities. But because of lack of basic needs, transport being at the top, a bit of lunch, you find the attrition rate of those community health volunteers is extremely high. Now, in terms of the community health package, the more I sat, I realized they need to teach on nutrition, they need to teach about NCDs, they need to teach on SRHR components. I'm also asking myself, what is the cadre of most of these community health volunteers in terms of their education background, the quality of assimilation they themselves will retain, and therefore be able to propagate to communities without misinforming them or giving half-baked information. I'm happy Anisa's presentation clearly showed. It shows that the education forum, school programs seem to be where most of this dissemination should be happening. So I want to provoke each one of us. What are you doing within school programs? How can we dent getting information to teachers, informations to the primary consumer we are talking about today and this week? That's the adolescent and the youth. And hopefully, should we think about making it a curriculum that is questionably examinable? That's my food for thought, because it's very clear, wherever you examine a child on a given curriculum content, it tends to get retained better. Number two, I think that's the golden opportunity in which it can percolate into communities by virtue of children going back home and educating households, and then the ripple effect from there. So those are two things. Prevention has always been better than cure. And I think my presenter on NCDs, actually virtually all of you, have talked about prevention, and health promotion. I'm missing one element, and this is, can we begin to educate the adolescent and the youth on self-care? Self-care, because when we're getting to see them in the hospital, I think it is too late. This physical inactivity these wrong food choices. If they have the information, then they should be able to act with that information. And the best is self-care. Even with oncology, I know we didn't speak about it. HPV vaccination is a preventive precaution, but we are now moving into the realm of even self-testing, even with cervical cancer, with the diabetes, with the hypertension, with the body weight and body mass index. Again, it is very easy for a child to actually take their weight, take their height, and get to know their BMI. But unless educated and informed, self-care, I think, is where we ought to really be looking at going. With even the simple technologies, and having come through COVID, much as we were saying, do teleconsults, we should begin to have that advocacy message. And then finally, this is my last take home. The media, and the media in all its facets. In other words, the channels that you're going to use, whether it will be a televised issue, whether it will be a newspaper cutting, or whether it will be the blogging and tweeting that they do, I think we really need to do a lot more in terms of informing, educating, and communicating, simplifying messages such that the basic Kenyan cannot hear medical jargon, but can actually understand and comprehend what is the message, and really delivering it in concise and simplified manner. So this has been my take from what I have listened. I really appreciate all the presenters, and I really appreciate the fantastic moderation that has gone on. There are many people who are asking about the slides. We must get consent from the people who have given us these presentations, but they will then be archived in the KNH repository for anyone who would wish to access them. So those who will be agreeable, you will be able to access them. And with that note, I want to invite you at 5 o'clock. We have a few good sessions where the community now begins to talk. So thank you very much, and thank you for a very, very well-versed afternoon. Thank you. Dr. Kinuthia, anything you'd wish to add?
No. Thank you, Dr. Kihara. I think you have summarized everything very well. Let's meet at 5. We continue the discussion. Thank you.
Thank you.
Okay, thank you.
Bye, everybody.
Bye.
Bye.
Bye.